Welcome all. This is Dr. Hani Nadeem. In this lecture, we are going to study the general features of the bones of the lower limb. Bones of the lower limb include the pelvic girdle, which includes the hip bone, the two hip bones articulating together. One bone in the thigh, which is the femur. In front of it, there is the patella. Two bones in the leg. There is the tibia medially and the fibula laterally. And we have the skeleton of the foot made of tarsus, metatarsus, and phalanges. We will start by studying the hip bone, or innominate bone. It's actually made of three bones which articulate together in a Y-shaped cartilage in this depression that's called acetabulum. This cartilage is called triradiate cartilage. It fuses together at puberty, making one bone. In this bone, we can see the following features. We can see this foramen, which is called obturator foramen because it is closed by an obturator membrane. Above it here, we have a depression called the acetabulum for articulation with the head of femur to make the hip joint, which is a very strong joint. Then the three bones, the one above is the ilium, and the two below, the one anterior is the pubis, and the one posterior is the ischium. We will look first at the acetabulum. We will see this articular surface in a crescentic shape. It's very smooth. It's called lunate surface. Inside it is a depression called acetabular fossa. It's not articular, it's filled with fat, and it ends below in an acetabular notch, which is typically transformed into a foramen by a transverse acetabular ligament. Now we'll see the features of the ilium. Its upper border is called the iliac crest. It shows a rough tubercle 5 centimeters behind its anterior end. It's made of two curves. The anterior 2/3 are convex laterally, while the posterior third is concave laterally. There are 4 projections, 2 anterior iliac spines and 2 posterior iliac spines. Anterior superior iliac spine, anterior inferior iliac spine, posterior superior iliac spine, and posterior inferior iliac spine. And there are 2 surfaces. The outer surface is called gluteal surface. It shows 3 gluteal lines. The posterior one starts from the posterior inferior iliac spine to reach the iliac crest, 5 centimeters in front of the posterior superior iliac spine. The middle one, which sometimes we call it anterior, starts from the middle of this notch, which is called the greater sciatic notch, till the tubercle of the iliac crest. The inferior one starts from the apex of the greater sciatic notch till the anterior inferior iliac spine. Now, the medial or inner surface shows 3 features. An iliac fossa, an auricular surface, which looks like an auricle. It's an articular surface with a similar auricular surface on the sacrum to form the strong sacroiliac joint, which is supported by a ligament attached to this rough area behind the auricle that is called iliac tuberosity. As a matter of fact, this ligament is the strongest ligament in the body. Now the pubis. The pubis is made of a body and the 2 rami. The body, here it is, makes the symphysis pubis medially, and on its superior border we have a line and a projection. The line medially is called the pubic crest. The projection on its lateral end is called the pubic tubercle. It may not be apparent on this side, but it's seen here. The 2 rami are a superior pubic ramus and an inferior pubic ramus. The superior pubic ramus shows also a line and a projection. Sorry. The line is the pectineal line, and the projection is the iliopectineal eminence. The inferior pubic ramus joins the ischial ramus to form together the conjoint ramus or the pubic arch. Now we'll see the features of the ischium. It's made of a body and one ramus. It has two projections and two notches. The two projections are the ischial spine, here it is, and here it is, and the ischial tuberosity, here it is, and here it is. The ischial spine separates two notches, a greater sciatic notch and a lesser sciatic notch. Regarding the orientation, that's how to tell whether the bone is right or left. This is not actually of practical medical value, but it's of medico-legal value. That if you are given bones that were found, and you can tell whether it's right or left, whether they belong to one person or more than one person, and so on. Okay, how can we tell if the hip bone is right or left? Of course, we have the acetabulum laterally, the iliac crest above, and the ischial tuberosity behind. As we said before, you know the directions in the three directions in space: superior, inferior, anterior, posterior, median, and lateral. And if you know one direction, you don't have to tell the other. The anatomical position of the pelvis is that the anterior superior iliac spine and the symphysis pubis of the two hip bones, all of them touch the vertical plane or touch the wall. That's how you can put the articulated pelvis in the anatomical position. Regarding the articulations, I said that the acetabulum articulates with the head of femur to form the hip joint, a very stable joint. The auricular surface of the ilium articulates with the auricular surface of sacrum to form the sacroiliac joint. And the two bodies of pubis articulate by a secondary cartilaginous joint called the symphysis pubis. Now, the sex differences. How can we tell whether it is a male or a female pelvis? Clinically, this is important in gynecology and obstetrics, and medico-legally also to know whether a bone found belongs to a male or a female. Well, can we tell whether a bone is a male, hip bone is a male or a female bone? Yes, we have several criteria. Generally, we have to know that the female pelvis is wider and shorter. That's why, that's because the female gives birth to a baby. So the span or the distance that the baby has to pass through should be short, and the pelvis should be wide to accommodate the fetal head. In addition, generally males have larger articular surfaces, larger, stronger joints, and stronger muscles. So let's see how this is reflected on the features of the hip bone or the articulated pelvis. Number one, this angle, which is called subpubic angle. See the difference? In the male, it's narrow. As we said, the pelvis is narrow. Well, if you measure the angle here, it typically accommodates the angle between your index and middle fingers. But the angle in the female is wider. It accommodates or it measures the distance between or the angle between the widespread index and thumb. The second difference is the shape of the obturator foramen. In the male, it's oval. In the female, it is large and triangular. Regarding the size of the acetabulum, since the joints are larger in the male, the diameter of the acetabulum is much more than the distance from its anterior border to the symphysis pubis. However, in the female, the diameter of the acetabulum is shorter than the distance from its anterior border to the symphysis. One thing, because it is small and because the pelvis is wide. So this distance is more than this diameter. Now, the ischial spine and ischial tuberosity in the male, they are not everted. They are pushed inwards, but in the female, they are everted outwards to widen the pelvis. Also, the sciatic notches, since in the male the pelvis is longer, they are narrow and deep, while in the female they are wide and shallow. The preauricular sulcus in front of the auricle is typically present in a female that has given birth to a baby, and you will know that later in obstetrics. Okay, the second bone is the femur. It's the longest bone in the body. As any long bone, it has an upper end, a lower end, and a shaft. Its upper end shows the following features. First of all, the head, which is about half a sphere or a little more. It fits very well in the acetabulum. That's why this joint is strong. It has a depression or a pit called the fovea capitis. It's for attachment of a ligament that carries blood supply to the head. It's called round ligament or ligamentum teres of the head. Following the head, this long span is the neck. It's not just a constriction, it's long here. That's why this joint is strong and gives a quite range of, very good range of movement. Following the neck, at the junction of the neck with the shaft, we have two trochanters, similar to what we have said in the humerus. Two tuberosities, here two trochanters. This is the lesser trochanter, which appears posteriorly, and laterally here we have the greater trochanter. The greater trochanter curves medially like this, overhanging a depression called the trochanteric fossa. At the junction of the neck and shaft anteriorly, connecting the two trochanters, is an intertrochanteric line, while posteriorly at this junction of the neck and shaft, between the two trochanters, we have an intertrochanteric crest. In the middle of the intertrochanteric crest, we have a quadrate tubercle. Now let's come to the shaft. Anteriorly, the shaft appears very smooth, no features apparent in it, but posteriorly it looks rough. In the middle third, we have this rough ridge that is called linea aspera. It has two lips, a medial lip and a lateral lip. In the lower third, the two lips separate, forming medial supracondylar line and lateral supracondylar line. This is the medial and this is the lateral. Also in the upper third, the two lips of linea aspera separate. Medially, it forms the spiral line that reaches to the lesser trochanter, and laterally it forms a rough, wide line that is called the gluteal tuberosity that has medial lip and lateral lip and reaches the greater trochanter. Now we'll come to the lower end. The lower end is made of two condyles, a medial condyle and a lateral condyle. This is on the anterior surface, a medial condyle and a lateral condyle. These condyles articulate with two condyles of the tibia. The difference between the two condyles is that the medial is curved. Although it looks smaller, but it's larger actually than the lateral. The lateral looks larger because it projects more anteriorly. It is straight, not curved, and projects more anteriorly. We will know why in a while. Anteriorly and posteriorly, the two condyles make two differences. Posteriorly, they are separate from each other. They are separated by what's called intercondylar notch that is limited above by an intercondylar line. However, anteriorly, the two condyles are fused together to form a patellar surface, an articular surface with the sesamoid bone that is called the patella. This patellar surface has a groove that divides it into a large lateral part and a small medial part. Why the lateral part is large? That's because the lateral condyle projects more anteriorly, as we said. And why is that? That's because the patella is under the pull of a tendon of large muscle called quadriceps femoris. Its pull is upwards and laterally. That's why the patella tends to be dislocated laterally. And the lateral condyle of femur projects more anteriorly and giving the patella a larger surface to articulate with to prevent its lateral displacement. Above each condyle, laterally and medially, we have the two epicondyles. The medial epicondyle has a feature above it, which is the adductor tubercle. And the lateral epicondyle has a feature below it, which is a groove for popliteus muscle. Now, how can we orient the femur? That is to say, identify its site. Well, the head is directed above and medially. So the head gives you two directions in space. Now remains what's anterior and posterior. The patellar surface is anterior, intercondylar notch, linea aspera, lesser trochanter, all of these features are posterior. We have two angles in the femur. One is called angle of inclination. It's actually the angle between the axis of the neck and the axis of the shaft. This angle is about 126 degrees. Why this angle is present? That's because the two heads of the two femurs are widely separated by the pelvis, by the hip bones. However, the two lower ends are close together because your two knees can touch each other. So here, between the pelvis and the two femurs, there is a triangle. All right? That's why we have this angle. If we don't have this angle, we would walk with our knees widely separated from each other. This angle is smaller in females. Why? Because the pelvis is wider. So that's why the inclination of the femur is more. So that's the angle is smaller. The second angle is called angle of torsion. It's the angle between the axis of the upper end and the axis of the lower end. The axis of the upper end is directed laterally and forwards. The axis of the lower end is almost horizontal. The angle between the two is the angle of torsion, which is about 12 degrees. This is a top view, okay, showing the axis of the upper end and the axis of the lower end, and this is the angle between them. Now we'll talk about the ossification. Remember, in the upper limb, I told you that if you put your hand on your knee, these ends ossify late. That is to say, the knee, the lower end of femur, the upper end of tibia and fibula ossify later than the other ends. Regarding the upper limb, the lower ends of radius and ulna and the upper end of humerus ossify late, while their lower ends ossify early. Sorry. Okay, so we have a primary center that appears in the shaft. Typically, all primary centers appear in the 8th intrauterine week. As a matter of fact, the femur is probably the second bone to start ossification after the clavicle. It starts earlier than the 8th week, maybe in the 7th week. The secondary centers appear after birth, typically in the upper end in many places and in the lower end. These centers form a bone, but they are separated from the shaft by the epiphyseal plate. The epiphyseal plate in the upper end fuses early, that's right, at 18 years in the male, 2 years earlier in females, 16 years. While in the lower end, they fuse with the shaft at 20 years in the male and 18 years in the female. There is a fact that I have to tell you that in the knee, that is to say in the lower end of femur and the upper end of tibia, the secondary centers of ossification may appear just before birth in late intrauterine life. These are the only secondary centers that appear before birth. Now we will come to the patella. The patella is the largest sesamoid bone in the body. As you can see here, it is triangular in shape. This is the anterior surface. This is the posterior surface. It has an apex, which is directed below. It has a base, which is directed above. Of course, we have a lateral border and a medial border. This is the right patella. We have an anterior surface, which is rough, and a posterior surface, which is smooth because it is articular. As I said before, it articulates with the patellar surface of the femur. And it is divided by a vertical ridge into two articular parts, or two facets. The lateral one is larger than the medial one because it articulates with a larger area in the femur, while the medial articulates with a small area to prevent lateral displacement of the patella, as we just said. Regarding its side orientation, if you put the patella on the table, usually it rests on the large lateral facet. That's how you can identify it. The apex is below, and the base is above. Rough surface is anterior, smooth surface is posterior. Now, how can you tell whether this is large or small? You just put it on the table and it rests on the large lateral facet. Now we will study the tibia. The tibia, as a large bone, has an upper end, shaft, and a lower end. Okay, let's see what's in the upper limb. What are the features? It's made of two condyles that articulate with the two condyles of femur. When we look on the upper aspect, we will find that the medial condyle is large and oval, while the lateral condyle is small and circular. Just behind the medial condyle, there is a groove for the semimembranosus, while just behind the lateral condyle, there is a facet for the fibula. So you have to tell the differences between the condyles and a feature related to each condyle. Between the two condyles, we can see here what's called intercondylar area. In its middle, there is an elevation called intercondylar eminence, leaving an anterior intercondylar area and a posterior intercondylar area. And you will study in the hip joint the structures related to the anterior area and structure related to the posterior area. Anteriorly, we have the tibial tuberosity. Its upper part is smooth and lower part is rough. Strange that the smooth part gives attachment to ligamentum patelli, the ligament of the patella. The rough lower part is related to a bursa. You may wonder, how can an attachment leave a smooth area? Typically, attachments of muscles leave rough area. However, attachments of ligaments leave smooth areas. The features that we can see here, the main features, we have a lateral border, which is called interosseous border. We have an anterior sharp border, which is called shin of tibia, that can be felt subcutaneously between a medial and lateral surface. On the posterior surface, we have an oblique line called soleal line. Here it is. And below it is a vertical line. And close to the vertical line, we have the nutrient foramen of the tibia. The lower end of tibia projects medially downwards, making the medial malleolus. Laterally, it shows a facet for the fibula. It does not articulate directly with the fibula, but there is a ligament connecting both, because the inferior tibiofibular joint is a fibrous joint. Inferiorly, there is an articular surface on the tibia and medial malleolus that, together with the lateral malleolus of fibula, they make a cup that articulates with the first tarsal bone, which is called the talus, to make the ankle joint. Posteriorly, we have a groove behind the medial malleolus for the tibialis posterior muscle. Regarding the orientation of tibia, you can tell that the two condyles are superior. The medial malleolus is inferior, and medially, the soleal line is posterior. The tuberosity is anterior. Now we'll come to the fibula, a very slim, long bone. It articulates in the ankle, as we just said. It articulates with the tibia, making the inferior and superior tibiofibular joint. However, it does not articulate in the ankle. The ankle is between the three bones: the humerus, the femur, the tibia, and the patella. The main function of the fibula is giving muscle attachments. That's why surgically, when an orthopedic surgeon needs a bone graft, usually they take the fibula for grafting. As any long bone, it has an upper end, a shaft, and a lower end. The upper end shows the head, which projects, forming the styloid process, and it has a circular facet for the superior tibiofibular joint. Following the head, this constriction is the neck. Regarding the shaft, it has an interosseous border connected to the interosseous border of the tibia by an interosseous membrane. Anteriorly, there is an anterior border that splits below, making a triangular subcutaneous area. May not be apparent in this picture. Posteriorly, it shows in the posterior surface what we call the medial crest, which shows a nutrient foramen close to it, similar to the vertical line of the tibia. The lower end of fibula projects downwards, making the lateral malleolus, and you can see that it projects lower down more than the medial malleolus. On the medial surface, we can see a triangular facet for the inferior, for the ankle joint. It articulates with the talus, and just behind it, we have a depression called malleolar fossa. And by this malleolar fossa, we can identify the site. So to orient the fibula, typically we look at the lower end. Below, we have a triangular facet, not a circular facet, and the malleolar fossa is medial to it. So we can tell that what is inferior, these two features, what is anterior and what is posterior. Both of these are medial structures. And we said regarding the ossification of the tibia and fibula that the upper end typically ossifies late or joins late, and the lower end joins earlier. Now we will come to the skeleton of the foot. The skeleton of the foot is made of 7 tarsal bones, 5 metatarsals, and phalanges in the toes. Why you may wonder why we have 7 tarsal bones and 8 carpal bones. One of the carpal bones is actually a sesamoid bone, which is the pisiform. So they are really 7 plus 1 sesamoid. Well, what are the names of the tarsal bones? The first one here is called talus. The one below it is called calcaneus. The talus articulates here with the navicular, and the calcaneus articulates with the cuboid, which looks cubical. The navicular articulates with 3 cuneiform bones, which are wide above and narrow below. Okay, they look like wedges. That's why they call them cuneiforms. Each cuneiform articulates with 1 metatarsal, and the cuboid articulates with the 4th and 5th metatarsal bones. You can see that the axis of the talus rests on top of the calcaneus. The axis of the talus goes medially to articulate with the navicular, and the navicular articulates with 3 cuneiforms, and the 3 cuneiforms articulate with the first 3 metatarsals. The calcaneus, cuboid, 4th and 5th metatarsal bones. Let's see some details of these bones. The talus looks like a turtle. It has a head followed by a neck and a shell called the trochlea. It is smooth on the upper surface, medial surface, and lateral surface to articulate with the cup made by the tibia and fibula to form the ankle joint. The calcaneus is box-like. It is directed forwards and laterally. It has a medial shelf here. It's not shown because it's under the talus from the top view, but it's seen from below. It's called sustentaculum tali. It's a shelf that holds the talus upwards. The cuboid bone on the undersurface shows a transverse groove for a long tendon that goes to the sole of the foot called tendon of peroneus longus or fibularis longus. The navicular projects medially, forming a tuberosity. The 3 cuneiforms, the medial, the middle, and lateral, are wedge-shaped, wide above and narrow below. That's why they make what's called the transverse arch of the foot. The metatarsal bones are 5. The largest one is the first. They are counted from medial to lateral. So this is first, second, third, fourth, fifth. The fifth has a projection here called tuberosity. They are considered as long short bones because they have one end and the shaft. This is the head, this is the shaft, and this is the base. Same appearance for the phalanges. We have 2 phalanges in the big toe and 3 in each other toe. They are proximal, middle, and distal phalanges. Also, they have base, shaft, and head. Well, this is the end of this lecture. Thank you for listening. If you like the lecture or find it useful to you, please subscribe to my YouTube channel and hit like. Thank you again.